Yeah, just my take on things. My answer to number 2. Guide discovery. Identifying and challenging your beliefs. Reframing your mind, negative thoughts release. Those cognitive distortions decrease.
Welcome to another episode of Peplau's Ghost. I'm your quote-unquote host, Dr. Dan Wesemann from Iowa. I'm joined by my esteemed colleague, Dr. Melissa Chapman Hayes, and I am really excited. The podcast is going international, in my opinion. So really excited to get to talk to Gisli, who is from the University of Minnesota, and also is from Iceland.
Yeah, that's where I live now. Yeah, I'm a professor at the University of Akureyri, which is in the north of Iceland. So I live
Wonderful.
kind of on the 66th latitude.
Wonderful.
That's where I am now. Yeah.
My wife is from Minnesota, and so she always reminds me, and correct me if I'm wrong in the thinking about this, but Iceland is green and Greenland is more ice. Is that a common acronym, or is that common stereotype or bias, or am I way off on that?
Yeah, I don't know. Yeah, sure. I mean, it's a little warmer in Iceland. We have the Gulf Stream, and we're a little bit more to the south, and we're not as proportionally not as covered in ice. So yeah, but it's still
wonderful.
a rough place. It's still a rough place. It's yeah. As far as islands are concerned, this is a rough place to stay. Really.
Wonderful.
Well, I don't know about that. So I lived in Iceland for 10 years now. I moved back in 2014, but
14.
I still have adjunct faculty positions at the University of Minnesota and teach a course there at the Center for Spirituality and Healing and things like that. So.
Thank you. Yes. So yeah, I was seeing, and I was kind of doing a little bit of internet snooping on you and seeing kind of some of your work and your history, and was really impressed with the work you've done with integrative care and integrative nursing, and the paper you wrote back in 2015, kind of laying out kind of the principles of integrative nursing, which was really impactful. I really kind of loved kind of the wording and kind of just really hit home for me. It just really kind of seemed like, and again, I think, for those listening, it's obviously Peplau's Ghost is one of those podcasts that's meant to highlight the use of psychotherapy and, continue to utilize that in a nursing role. So I think that for me, and I'm happy to, kind of hear your thoughts on that too, integrative nursing using holistic approaches, treating, the person individually and not kind of lumping people into those medical models. I think that this podcast is warm and receptive to that. So again, very much appreciate you joining us today. So I get we kind of, as we do typically with our podcast, we kind of go back and forth asking questions. So I'll get the first question us going. When did you first get interested in doing or in, being involved with psychotherapy?
Well, I think back in maybe 2004 when I graduated from the School of Nursing and at the University of Iceland, and started working in psych. I got interested in that, and that's why I pursued a graduate degree at the University of Minnesota back in 2006. And so I was interested in doing psychotherapy and developing that role. Then, as many of the listeners are going to be familiar with in advanced practice, especially in the U.S., you get the prescription pad as well, and it pays a little better to do that. So you have to fight for your role as a psychotherapist. But it really has been. It's been from the very start. I've been interested in the psychotherapy or the psychotherapist role.
Yeah, thank you. Kind of a follow-up, sorry, kind of jumping on Melissa's toes, but I guess one of the questions came up just a bit thinking about that response. Did the University of Minnesota offer kind of some educational opportunities for you that the University of Iceland did not, or why did you choose to come to the United States to kind of develop those skills, or were there not that opportunities at the University of Iceland?
Well, I don't know if you guys know this. The U.S. is not best at everything, but the U.S. is pretty advanced when it comes to advanced clinical nursing. Other countries are getting better. Australia, Netherlands, UK, Ireland, but But when it comes to advanced practice mental health nursing, back in '05 when I was looking at this, the US had the most exciting clinical degrees. In Iceland, it was really more theoretical stuff. And so I didn't just want to learn how to think. I also wanted to learn how to do. And so so that's why I came to Minnesota and decided to go to the United States to get my graduate degree, so I could get an advanced practice degree, not just a theoretical, degree.
Thank you. Yeah, that's good. I appreciate that, and I appreciate you calling us out in the United States. Right, we're not the best at everything, so thank you.
Well,
Appreciate
but
that.
you're kind of the best at this, though. So that's pretty cool.
We'll hang the hat. Yeah, thank you.
Yeah.
Speaking of practical, it would really be fascinating to hear about a session that really taught you something. So it could be early on or really any point in your career. Just kind of looking for an example of a session that really stood out to you and why.
Well, there's a couple of things. I mean, one of the requirements to which is cool at the University of Minnesota is that historically speaking, and I don't want to get into the whole CNS versus NP versus DNP thing. We kind of wrote I'm one of the co-editors of a book called Advanced Practice Mental Health Nursing, a European Perspective, for those interested in more kind of discussion on this. But at the University of Minnesota, there's a long tradition of producing CNSs until the consensus back in 2015, where we all decided we're going to be NPs. And so I took that licensure back in 2015 as well. But anyway, so when I was starting out, at the University of Minnesota, we were in a CNS program, although it had a lot of what we would call now NP competencies. I don't know if I lost like all the audience now, and Melissa is like losing
different certifications. I mean, I do know what they stand for.
Yeah.
I don't know that. Yeah,
the different competencies. Yeah, it's a whole thing. Anyway, so one of the requirements was to do psychotherapy. And so I did that. I started psychotherapy in 2006, and I've been doing psychotherapy and clinical supervision as well since that time. So it's almost 20 years now, and I've tried all kinds of different approaches and different things. But one of the things that stood out is the first session I attended is I really felt the need to explain to everybody else in the waiting room that I did not have a diagnosable mental illness. And I was like, really, Gisli? Mr. Non-biased, non-prejudice, like, hey, good for you. Like, I just want to, there was a part of me who would stand up in the waiting room and says, I know all you people are here, because you have a mental illness. I'm just here for school, and I just want you. So that was a big revelation for me, because that this bias is so deeply rooted in me that I thought I was fine, So that was an early wake-up call for me, where I was like, oh, really? And I've had many since that time. One of the more interesting things that happened to me is I did clinical supervision with a great and a psychiatrist I worked with. He was probably 72 or 74 or something when I started working with him, and he was just great. Coming from kind of different roots and background, coming from the East Coast and thinking about things a little bit differently. And so once I was doing clinical supervision with him, and I asked, I've been working there for a year. It was a pretty hardcore kind of community mental health center I was working in. And I asked, his name is Jerry Kroll. So I said, Dr. Kroll, do you think I worry too much about things? Am I too neurotic about, patients and all these things? And he said, well, not until you asked me that question.
You fooled him until you asked the question. I love it. I know, we give ourselves away, don't we?
And I was like, damn it.
I love it.
So,
that's great.
Thank you. I've had a few of those, but those are two early ones that were kind of interesting.
Yeah. I appreciate the self-reflection in particular, which that was powerful.
Yeah.
Yeah.
Well, thanks.
Yeah. Yeah, very good. You were hinting at this, so this is a little bit more of a kind of a technical question we like to ask, but what forms of therapy or what types of therapy are you kind of drawn to? I mean, maybe kind of what did you first fall in love with and what are you kind of like doing now, or however you'd like to answer that question?
Well, first of all, I am a very poor drinker of Kool-Aid. That's it's really not. I just don't like to guzzle the stuff, you know. So I don't really get these. I don't get enamored by different philosophies and approaches where I feel like this is going to work for everything, you know. It's like nothing works for everything except oxygen and water, you know. It's like it just doesn't. I've never been able to. I often envy people who are able to get really kind of dogmatic about different psychotherapies. It's like, what am I doing wrong? Why can't I believe in this so much? So I'm really, you know, I just like stuff that works for people. So I have training in my latest kind of is EMDR, which is you know, evidence based for PTSD, where I do a lot of working with parts as well as a part of that. So I like that, but I also like supportive psychotherapy a lot. I think it's under taught. I think it's taken for granted. I think the components that help us build up the therapeutic alliance are often neglected, and we think they're going to come for free. You know, if we learn a new shiny therapy, the therapeutic alliance is just going to come for free somehow, that we're just going to get it because we're doing a shiny, fancy, manualized therapy. I don't believe in that. I think we really need to work at supportive psychotherapy, get training in that. And that's what we do in our program in Iceland. We developed a clinical training program, you know, with a lot of clinical hours, which was one of the reasons I went to the States, because there was none of that in Iceland. But, you know, so I like supportive psychotherapy too. And I urge people to look at that because it's so honest about just, we're going to work with what works for the therapeutic alliance. Basically going to do stuff that works for that, and then not going to do stuff that doesn't. And a lot of the work we're doing, especially with people with significant impairment or significant symptoms or in a crisis mode, we're doing a lot of supportive psychotherapy. And why not be intentional about it and honest with ourselves and other people what we're doing here? Why do we always need to call it something else? I mean, it has good evidence. There's clinical manuals. You can train it, you can teach it, you know, you can define it. So, yeah, I like supportive psychotherapy. I like motivational interviewing as well. I've had some training in that, and I just re-upped on my training this last year. And I feel that fits really well with supportive. I like something called and people can Google that if they want to. I like the why model of psychotherapy, of teaching psychotherapy, if you heard about that. Where the stem of the why is really stuff like supportive psychotherapy, motivational interviewing, therapeutic alliance, and then psychodynamic is on one thing and CPT is on the other branch of the why. And you know, it's such a cool way to kind of think about this. And the most complex even I do some CPT, you know, for depression and generalized anxiety as well. Nothing more specialized than that, but I still use it quite a bit. And I've gotten training in narrative therapy too, which came out of me. You know, I'm a big white dude from Iceland, and I just didn't have tools to work with people coming from different backgrounds, and I didn't have the framework really to do it. So I did a couple of years of narrative therapy training, which, you know, that was a long time ago, and it was, I don't know, around 2010, 12, something like that. And that's really stuck with me too. So different things, different, you know, things I've been interested in. Of course, my PhD is about adapting mindfulness practices or mindfulness-based intervention for people with traumatic brain injury and substance use disorders. So mindfulness is always big with me too, although that, you know, that can't be a part of psychotherapies. Now, I was into mindfulness like some other people probably listening before it was cool. Before the psychologist realized it was cool and wanted to own it.
it got a clicked, right? Yeah, there's a lot of clicky stuff with mindfulness. Yeah, it's
Yeah,
funny.
all of a sudden, like it's a part of all kinds of stuff, and I'm like, well, I've known it. It works for quite some time, but thank you. So yeah, there's different things, but I really have this really strange philosophy about trying to use the approach that works for the patient, not just what I know how to do, or what I think is shiny today. So, and there's, so trying to meet the patient where he's at, and not just saying, if you don't want to do EMDR, buddy, go over there. And if my approach doesn't work, there's something wrong with you. I think a big part of what we do with psychotherapy sometimes, especially I think nurses have a tendency to do this because of the strange power differential we kind of work with, but I think other professions who do psychotherapy do it too, is we like to blame people if our therapy doesn't work. Like, oh, he wasn't ready for treatment, or, like any other explanation other than us or our method or approach didn't work for that person. Like, we never like to kind of, because it's painful to do. And so I like to be kind of open, and sometimes I refer people out to do other things, like especially specified CPT. I have a lot of respect for, and not a lot of people have that training. I mean, people that use CPT may not have this specific like OCD, CPT for OCD training, or whatever it is. So, but so I have a few different. How can I say this? I've had affairs, but I've never gotten married to one of these things. Do you know what I mean? They're always kind of, as I said, I'm a poor drinker of Kool-Aid.
That might be the title of this episode, Poor
Yeah.
Drinker of Kool-Aid. I love it. That's a great analogy. Thank you.
Yeah.
The question I was going to ask actually segs really nicely from what you said, and I was on mute but laughing when you talked about like psychologists picking up mindfulness, because my training's in psychology.
Yeah.
But my question is, so like, why, in what ways is nursing a leader in providing psychotherapy?
I don't know if there's, I don't know if
or
there's,
can they be?
Yeah, I
Or
don't
not?
know. Yeah,
Okay.
I mean, for me, there's no evidence that one profession does psychotherapy better than another profession. I mean, you can just send me the articles if you've seen them. I haven't seen any data to suggest that. As long as there's adequate training, of course, and supervision involved. And so I don't really, to be honest with you, I think it's just good that we have different philosophical underpinnings of people providing psychotherapy. I think just everybody coming from kind of a same school of thought is not good. I think if we only had nurse psychotherapists, that wouldn't be good. And I think having somebody coming, everybody coming, like that's kind of the case in Iceland, where most psychotherapy is done from psychologists, which is great, but it's very hard to do something else, get something else than CPT. And I don't know if you heard this, but there are other things that work for mental illness, except for CPT. I mean, CPT works. I mean, and for some things it works best, but it doesn't work for everybody all the time. Because like I said earlier, nothing works for everybody except oxygen and water. So I think I don't really see it like that. I see it like as an interdisciplinary kind of like what do you call it? Like a Venn diagram, kind of almost like a thing where, a psychotherapy is a shared competency between some different professions, and providing they have the right kind of education and background, that quality is assured. I don't think one is going to do, I think I probably think it's going to be more when we look at data, or if we would look at data, I think it's probably going to be more personal, difference than profession, what profession you're coming from. But I think diversity is important when it comes to this. So I do think nurse psychotherapy is important, but I don't think it's more important than other kind of psychotherapy.
Yeah.
I'm sorry about that. I just don't route for nursing like a sports team. I don't. Like I route for the patients. I mean, I don't want to be facetious or pretentious here, but it's really the sports team I route for is the users or service users or the patients, we're working with. I don't really care so much about, I mean, I don't want us to do anything that's not that doesn't benefit them,
Yeah.
And I don't, yeah.
No,
So
I appreciate
does that make sense? Yeah.
it. Makes perfect sense, and I love the diversity and the embracing of multiple multiple professions can do psychotherapy. I agree. I mean, even physicians, they've done it as well. So it's not unique. I will kind of maybe give some background on that question. It's just kind of what sprung board a little bit of this podcast is the idea that there is some of us here in the United States, nurses, especially psych mental health nurse practitioners, who are concerned about the loss of use of psychotherapy within nursing, and so I think that's why we asked the question. But I love your answer and love that you root for the patients. So my next question kind of spins off that a little bit. Are you concerned at all about psych mental health and nurses using psychotherapy, or what are your yeah, I mean, you mentioned kind of, everybody's got same, similar approaches and things like that, but is anything about nursing that concerns you being a psychotherapist, or what are your thoughts on that?
No, as long as we just have, we have the same demands on nurses as we have on other professions providing psychotherapy. And I think it benefits some people to meet somebody who has more kind of can I say, like a medical background, or has some more knowledge of physical stuff, medications and things like that. I think we have people with chronic illnesses, for example, that benefit often from seeing somebody that has some insight and experience with that, and other things, people that are on more complex medications, side effects, etc., where I think a nurse psychotherapist would come in handy sometimes, and would have provide some deeper understanding in some areas, and then it's vice versa with other things. So no, there's no concern. I haven't seen any evidence to indicate cause for concern. It's more that that the prescription pad is so alluring, it's so tempting, and and I wrote about this in one of the articles that I did, and you probably read that, where it's just so easy to get to forget about other things, and we get paid more to prescribe medications, and there is this feeling of legitimacy, of course, because we get some of the glow from medicine on us as we do that as well. So there's legitimacy, and a lot of nurses are looking for legitimacy for very, very kind of legit reasons. So I think there's a little bit of it's almost like it's so tempting to reach for that, and it's such a powerful tool. So I think it was very helpful for me, because I can't prescribe in Iceland. I don't have prescriptive privileges here. And so when I moved back in 2014, I had to kind of reinvent myself a little bit. I'd done, narrative therapy training, and I had basic training in some of these interventions, but I got, I got advanced training in a couple of different things after I moved home, and it was good. And I saw that I started to think things a little differently. And, again, the problem, it's not, I use medications quite a bit in my team, and I advise on it. And so it's nothing against that. But we know that when you have a hammer, everything starts to look like a nail, And so that's why I think it's important for us when in our training programs, both in Europe and around the world, and in the US, that we continue to have psychotherapy as a core competency. And using something like the Y model, where we teach people, supportive psychotherapy in the very least, and some basic principles of some other things, and then they can go out and get additional training and certification, like often is done with these evidence-based interventions.
We did found a concern, and I agree. I mean, I totally agree. That's that allure of, like you said, everything looks like a nail when you got a hammer in your hand, and that hammer of a prescription pad is quite an alluring thing, as you mentioned as well. So thank you. Appreciate that perspective.
Yeah.
What do you see as the barriers for more PMHNPs using psychotherapy in practice?
Yeah, so reimbursement is, of course, the main thing, I think. First of all, lack of training in some of these programs, where people are kind of either don't have a competency like that, although they should, of course, but kind of pay up. Like there's a nod to it, but it's not serious. and so the students don't feel they're ready to do anything else except for prescribe and do those things when they crisis management, those things when they graduate. So that's one barrier. And the other barrier is reimbursement. As we know, I had to kind of fight for being able to do psychotherapy, and you have to kind of nudge things a little bit, and your clinic has to, give you 30 minutes. You get 30 minutes, and then the 30 minutes are kind of on the house, and so that's a big issue too. So you don't have these hour appointments. You do 30 minutes. You can get good at supportive psychotherapy though through that, and you can use some basic interventions. But doing in-depth psychotherapy with these evidence-based models is going to require some differences. And I talk about reimbursement because it's sometimes it may seem expensive to the institution to have us prescribers provide psychotherapy. And the psychiatrists, our colleagues in psychiatry, feel the same way. I know many of them. They're pigeonholed into out of psychotherapy. And these are maybe most of the brilliant and best educated psychotherapists we have sometimes. A lot of clinical training, a lot of in-depth stuff. And the system doesn't allow them to practice their art, if you will. So, and it happens to nurses as well.
No, I thank you again. And again, I'm really appreciative of this kind of international perspective, at least from two different countries, because that's the answer I would give as well, from the United States and only having that experience. So I'm assuming in Iceland is socialized medicine or do you have private insurance and such?
Yeah, it's socialized medicine. It's less pressing for us.
But still.
But because we don't prescribe, but we still need so many nurses, and so it's a little bit hard sometimes to sell that role. So we have to make sure that we give them adequate training, and there's always the psychologists are kind of new in Iceland compared to other countries, and so they're fighting for legitimacy and standing and power as well. And sometimes we underestimate the power of nursing. I mean, we're really like, I don't want to offend anybody, but we're really like cockroaches throughout the entire healthcare system. I mean, we are everywhere, and we often, we have power. So I think I have empathy towards professions that are not as established in the system as we are, because often when there are cutbacks and things need to change, they're the first ones to go, and we're just going to keep the nurses and the physicians. So, I mean, I have empathy towards that, but I do think it's important because sometimes we're the only ones that are there. Sometimes, especially in rural areas, especially when people are dealing with all kinds of complex chronic illnesses, and there's a need for that kind of holistic understanding of health that we have. That it's important to have some nurses that know how to do psychotherapy as well.
Yeah. So I again appreciate your time. I'm kind of running up on our allotted time here. So I've got one more question to kind of get you out the door. So what do you see for the future of psychotherapy within psych mental health nursing? What's your crystal ball tell you? Where are we heading, or where are we growing? Where do we need to kind of protect? What are your thoughts on that?
Well, the Royal College of Nursing defines kind of four main pillars of the advanced practice role. And I think with the advent of the DNP programs we have in the US, and maybe that'll become an entry into advanced practice in a couple of years, I don't know, in a few years at least. What we have is the opportunity to make sure that the psychotherapy competencies are held true in these programs. And with 3-year programs, we should have the time to do it. So, I think we need to fight for that, not fight other people. We need to fight ourselves. We need to fight our programs. We need to kind of fight for having that understanding, because I think it matters to the patients. I think it matters that we have some core competencies and basic knowledge, and maybe advanced knowledge in some cases. I think it matters for career development that we can pivot. Like I was able to pivot into psychotherapy. That's my main role today. And I do a lot of EMDR with people, and I do a lot of supportive psychotherapy as well. some basic CPT. I use quite a bit of motivational interviewing, so different evidence-based practices. Narrative therapy is always kind of playing in the background. So, I think it's important, for all kinds of reasons, that we keep those competencies in there. And as well as we're not even gonna, supportive psychotherapy is the most complex of psychotherapies. I mean, we use that with the people that have most symptoms and are the most complex to work with often. And it's not new and shiny and fancy, and the other kids don't envy us because of it. It's still often the most complex work I do. And I know a couple of shiny things, but still the supportive psychotherapy bit is it's often poo-pooed and looked down upon. And I think it's a very important competency to have as well. So I think, I think that's the future. Is we need to focus on the therapeutic alliance, and I think we need to focus on teaching people how to establish that, maintain that, and if they're able to do that, it's easy for them to add other competencies on top of that, and they'll be good psychotherapists in whatever direction they choose to steer themselves. And they're also going to be better prescribers and better crisis management people and better evaluators and better at anything that has to do with the patient,
Yeah. Thank you. Thank you for your perspective. This has been great. This has been, I hope anyone out there listening gets as much out of this as I do. So please like, subscribe, drop comments. Happy to kind of share those information. If there's a couple of references that Dr. Gisli mentioned, I'm happy to kind of share those as well. But thank you so much for joining us, and look forward to another episode coming your way soon. Take care.
Thanks.
Identifying, challenging your beliefs, reframing your mind, negative thoughts release. Let it go. These cognitive distortions decrease until they cease. Yeah, guided discovery. Identifying, challenging your beliefs, reframing your mind, negative thoughts release. Let it go. These cognitive distortions decrease until they cease.